Then you can also use pulpotomy when you have a tooth that doesn't stop bleeding after pulp cap or for pulp capping or shallow pulpotomy. You remove the roof of the pulp chamber, and then you just go ahead and remove the entire pulp from the pulp cavity, and then you just go ahead and pack your MTA or other materials in there. See, this is from that study that Dr. Payruch and his associates did, and as you can see here, we have a nice layer of dentin in the orifice of this canal in dogs. And this is a higher magnification. As you can see here, solid dentin and a nice layer of dentin and odontoblast there. So here is a case that I received from Dr. Lindemann from Michigan. Open apices, lots of decay. So what he did was he removed the pulp completely, stopped the bleeding, put MTA in there, and then he did it in 2 stages. He put wet cotton pellet in here, and then cab it, and then he put a permanent filling. And this is after a year, and this is actually after 14 years. As you can see here, the apices are closed and everything looks fine. The prognosis of these cases is very, very good based on the study that I referred to before. It's somewhere between 72 to 99%, and it depends on whether the teeth have open apices or closed apices. The last thing that I would like to discuss is regenerative endo, because it has to do with production of the pulp and vital pulp therapy. This is the definition of it. The objective is to grow normal tooth structure within the root canal, and we want to have pulp in there and normal periapical tissues. Here is an example of a case that we usually do, or the procedure that we usually do. So what you have is you have necrotic pulp, open apices, you make your access preparation, you clean and shape the canal, then you put your antibiotics there, triple or double antibiotics, you leave it in there for 3 weeks actually, and then you put your temporary filling, you bring the patient back, and then you create bleeding, and then you put your MTA in there, and then the glass ionomer, or you do it in 2 stages. And if everything works out fine, what you're going to get is closed apices and some sort of a tissue in here. One of the questions that comes up is what type of tissue we get. Here is a case that was done as a part of our multi-center study with the University of Texas in San Antonio and also University of North Carolina and Maryland. As you can see here, this is an open apex, large lesion. We did the region, and this is after a year, and this is after 2 years. One of the questions that comes up is, what type of tissue do you get here? Based on what it is in the literature, you're not getting pulp. Actually, you're getting either cementum or bone or sometimes dentin in there. And this is from a study that we did in ferrets. We've done a number of studies in ferrets. And as you can see here, the apices are open. And when we extirpated the pulp, this is what we got. And, and then we waited for a few months. As you can see here, the bone has grown inside the tooth right against where the MTA was. Now, how can we get actually true regeneration? I believe that there are 2 factors involved. If you have some pulp tissue left in there, you've got a good chance that you're going to get pulp going back and be vital there and fill the whole tooth. And the other thing is, if you do the procedure immediately after pulpal death. See, here is an example. This is a tooth that was going to be extracted. The patient came to our practice, and this is a dense indente, as you can see here. When I opened up the tooth, I saw vital tissue in here, and I packed it with MTA, and I told the patient, come back in a few months. And then the patient or the referring dentist, sent this picture to me, after 4 years or 5 years. As you can see here, the tooth was completely regenerated, the pulp was there. And the reason for that was because we had normal pulp and periapical tissues there.